is noon and we'll get started. Good afternoon, everyone. Welcome to Pediatric Grand Rounds. I'm Dr. Gayatri Jayashankar. I'm one of the general pediatricians with ETSU Pediatrics. Before we get completely started, I would like to cover a couple of housekeeping items. Number one, very, very important for us, please, all of the folks in the room, medical students, residents alike, please sign in to the Grand Rounds number that's in the back and put in the event code number. We count our number of people who come to Grand Rounds based on your calling into that number. If you've not done this before, what will happen is within the next week you'll get a text saying, we don't know who's associated with this number, please give us your information. And then in following events, it will automatically recognize you and give you credit for attendance as well as CME credit if you require it, okay? So please, can I remind everybody to sign in with that number in the back. Number two, again, very, very important, please fill out your evaluations at the end of the session. Again, this is a requirement for us to be able to continue CME and Grand Rounds. So please make sure that you do that. Again, it's my pleasure to welcome Dr. Saeb to give his Grand Rounds presentation. Dr. Ghassan Saeb came to us in July of 2012 and is now one of our senior residents, ready to graduate. He will be going to sunny, beautiful California, I believe, to practice general outpatient pediatrics, and that makes it very, very topical and important for us to learn about atopic dermatitis for the primary care physician from Ghassan. Ghassan came to us in 2012 after having done his medical schooling from Aleppo University in Syria, and then had also received some training in the US prior to joining residency with our program. He has been a wonderful active member of our resident class, involved in many, many, many projects, presentations, our events. If any of you have worked with Ghassan, you will know him to be a very accurate, concise, thorough, wonderful physician, and also with a great sense of humor, which only comes out after a few days of spending time with him. So I'm looking forward to Ghassan's presentation. Again, welcome.
Thank you. Thank you for this nice introduction. Can everyone hear me? Okay. Dr. J just left out of my CV. I am part of the sick leave committee. So I'm going to talk today about atopic dermatitis for the primary care. And the reason I chose this subject, in March I had actually dermatology rotation. I love dermatology. And during that month I have an interesting patient. She was 3 months old. Interesting and challenging. And initially I decided to do child obesity, then I changed that, but I did a lot of work on this presentation to do it for and a visiting immunologist, allergist, and I decided to do it for the Grand Rounds. So first, the disclosure, I don't have any conflict of interest whatsoever, and this is my statement up there. I'll start with the case. A 3-month-old female is seen at my clinic for dry skin and itching that has been getting worse for the last couple of weeks before I saw her. Parents could not associate the rash, the dry skin, with anything in particular. She was breastfed baby along with some formula supplement. Past medical history, she was full term with no complications. Family history, significant for mother had history of childhood asthma. Father has skin eczema. Medications, she was not on any medicine. She had no allergies. Immunization, she had the 2-month shots. Developmentally, she was within normal limits. Social history, she lives with her parents who were originally from Saudi Arabia. No pets, no tobacco exposure. On exam, patient looked well hydrated, gained appropriate amount of weight. She was still below the 3rd percentile. She had generalized xerosis or dryness and pruritus or itching, like incessant all the time while I was examining her. The rash spared the diaper area, the nose, and the medial aspect of the cheeks. I didn't have a baseline picture for her, but this is a Nielsen picture. It looked very similar to this. The scaly rash on her head. She did not look as erythematous or red as this one because her skin color is a little bit darker, but her skin pretty much like this, except the diaper area. So the diagnosis was at that time atopic dermatitis, probably moderate to severe, and I provided some counseling for the parents, which included, number one, apply skin moisturizer and choose the unscented products. And I have a list from the dermatology, Cetaphil cream, Eucerin, Lubriderm, CeraVe, Aquaphor, anyone that the parents are comfortable using. Use unscented products for shampoo and laundry. Avoid excessive showering or bathing. That was controversial, but that's what was my recommendation. And follow up in 3 to 4 weeks, depends on how she does. 3 weeks later, on her follow-up appointment, mother reported that the patient has been having fevers since the night before the visit, 102 to 104, with some very mild redness on the right leg, with some mild runny nose for a couple of days. On exam, she appeared mildly ill, but she was afebrile. Skin remained dry, itchy, scaly, with very mild redness. I had to look very carefully to see the redness that the mother was pointing to. There was some tiny erosions. I thought probably it's irritation, nothing else. I didn't take picture at that time. And she had some cervical lymphadenopathy. Since she looked a little bit like ill-appearing with some tachypnea, we did just limited septic workup. We did a CBC, blood culture, urine culture, a chest X-ray. The CBC was higher normal, I think 14. Chest X-ray came back as normal. We did urine culture too. It was not enough to run a UA, but we sent urine culture. And we thought it probably viral. I counseled the parents for the possibility of skin infection, and I told them to come back for worsening symptoms. And I prescribed class 5 topical steroid for the skin problem, but they didn't actually fill it. And I changed the formula to Alimentum hypoallergic formula for some possible benefit for patients with atopic dermatitis. The next day I received a phone call from the father saying that the rash is getting worse. Now it's on both legs. The patient is still febrile. And I told them to come back to the clinic, and I saw her that afternoon. So she was febrile on exam. The lesion progressed to form oozing vesicles and pustules on both legs, worsening lymphadenopathy on lower extremities. There was no sick contact, no non-exposure to fever, blisters, or herpes. And she continued not to feed well. And this is her picture. This is the back of her knee. As you see, there's like oozing, erosions, there's intense erythema, and some skin breakdown. And this is the picture from the other leg, like punch-out lesions, as you see here. And it's erythematous, and she has some trouble also moving her leg, probably because it was very painful and sore. This is another picture. You see some honey-colored crusts on the feet, and these on the anterior foot. So the differential was eczema herpeticum, which is caused by herpes virus infection, impetigo, staph or strep, and chickenpox, since the lesion looked just some vessels. So I saw her with Dr. Mack, actually, and we decided to admit the patient to the hospital for IV antibiotics and IV acyclovir. White count that day was 24.2, up from 14, with 45% neutrophil, 40% lymphocytes, with no bands. During the hospital stay, she had immunoglobulin levels just to look for immunodeficiency, and they were normal. IgE was elevated to 75. This is the picture of her leg 2 days into therapy, and as you can see, that it's very suspicious for herpes, eczema herpeticum, clusters of small skin erosions, and this rash, I think, progressed up to her trunk or chest. So she improved on the acyclovir and I think vancomycin. She was hospitalized for 3-4 days. She had improved, and she was discharged on oral acyclovir and Bactrim. In the culture, HSV cultures were not back yet. I saw her in the clinic, and the HSV BCR was positive from the lesions and from the blood, which puts her at the diagnosis of disseminated herpes simplex virus. And she readmitted for IV acyclovir for 14 days. Then she went home without any significant complications. So this is just a picture from where I grew up, around where I grew up. So I'm going to talk about eczema, or what official name is atopic dermatitis. So commonly referred as eczema. It's a chronic, relapsing, and often intensely pruritic inflammation or inflammatory disorder of the skin. The concept of atopy was derived from the Greek etubia, meaning different or out of place, and was originated by Coca and Cook in 1923, the two physicians who classified the hypersensitivity disorders. Although the term eczema is frequently used, atopic dermatitis is a more precise term to describe this subset of dermatitis or skin inflammation. And as you know, we use eczema to describe this problem, but for any problem, itching problem that we are not really sure of the cause. Epidemiology, AD is one of the most common skin disorders seen in infants and children. Begins during the first 6 months of life in 45% of affected children, and in 60% and 85% of affected children before 1 and 5 years of age, respectively. Prevalence, a recent epidemiologic study using national data suggested that the pediatric prevalence is at least 10%, 20 to 30% in general population, which represented a marked increase during the past several decades. Studies performed before 1960 estimated the prevalence to be up to 3%. The subsequent steady increase has paralleled the increase seen in children with asthma, suggesting shared triggers. Atopic dermatitis occurs more frequently in urban areas than in rural areas, in smaller families, and in higher socioeconomic classes, suggesting that exposure to antigenic pollutants and lack of exposure to infections or other antigenic triggers early in life may play a role in the development of the dermatitis. Up to 80% of children with AD are diagnosed and managed by primary care providers and often pediatricians. The pathogenesis of atopic dermatitis is complex and multifactorial. It results from a complex interaction between immune dysregulation, epidermal or skin barrier dysfunction, and environmental interactions with the defective skin. And this is just a picture to represent what I just said. new data support that the theory that atopic dermatitis results from primary abnormalities of the skin barrier with secondary immunologic changes elicited by the easier penetration of immunologic triggers through an impaired epidermis. So I'm just going to, everyone knows the skin function, just to emphasize. The most important part of the skin function is to restrict water loss and to prevent entry of irritants, allergens, and skin pathogens. The outermost layer of skin, called the stratum corneum, is critical to the integrity of the skin barrier. And this is the stratum corneum up there with the rest of the layers. Filaggrin is a key player protein in the structure and formation of stratum corneum. And they found that loss of function mutation in the filaggrin gene, FLG gene, causes defective filaggrin protein. This was found in 50% of patients with moderate to severe atopic dermatitis in some demographic populations. Inadequate filaggrin production leads to a reduced ability of keratinocytes to maintain hydration and to restrict transepidermal water loss, which then leads to xerosis or dryness, and that drives the problem further. An inadequate skin barrier might also allow for the entry of aeroallergens, leading to an inflammation response and more erythema and itching. And I want to emphasize on itching. Itching brings more allergen antigen to the skin, in addition to that direct effect of rubbing, which recruits more inflammatory cells and markers, and thus perpetuating the inflammation. And they call this disease the itch that rashes. So itch it has very important role in the pathogenesis of the problem. Immunologic abnormalities further contribute to the barrier abnormalities, since the expression of inflammatory markers is known to suppress filaggrin's expression and causes more skin breakdown. There is another theory about the local pH. Change in the local pH can have like an impact on the skin infection and skin colonization with bacteria. I'm going to talk about the atopic marsh, which is very important to understand the pathogenesis of this disease. So mutation of the filaggrin gene is linked to both atopic dermatitis and asthma, but not asthma alone. And this supports the concept of atopic marsh, in which AD is the initial atopic disease during infancy, with the later occurrence of other atopic conditions depending on early allergen exposure through an abnormal epidermis, which cause epicutaneous sensitization versus the normal sensitization that we have through our mucous membrane or respiratory mucous membranes, and that can cause much powerful response. And if you look at this chart, this chart illustrates the chronological order of the atopic marsh. So it starts with the green line, the eczema. Then after that, the food allergy appeared. Then the blue line. This is where asthma appeared later, then allergic rhinitis. So asthma occurs in up to 50% of children who develop atopic dermatitis during the first 2 years of life. Allergic rhinitis develops in 43 to 80% of children with atopic dermatitis. Allergic keratoconjunctivitis, up to 30% of children with atopic dermatitis. So in general, children showing more severe dermatitis have a higher risk of developing asthma, as well as sensitization to food and environmental allergens. And this highlights the importance of effective skin treatment or skin-directed treatment of AD. It has been suggested that early optimal and successful treatment of AD may prevent or attenuate the development of atopic conditions. Roles of genes. It was suggested by concordance of 77% in monozygotic twins and the greater probability of having AD if one or even more so if both parents are atopic. Food allergies and atopic dermatitis. The relationship between AD and food allergy is complex but likely overemphasized. More than 90% of parents incorrectly believe that food allergy is the sole or main cause of their child's skin disease. True food-induced AD is rare. The resulting focus on food allergy can result in elimination diets, potential nutrient concerns such as protein or micronutrient malnutrition or deficiencies, and misdirection of treatment away from the skin, thereby leading to undertreatment. Effective treatment of the skin tends to allay parent concerns regarding food allergy. The most common cutaneous manifestation of food allergy are often IgE mediated and consists of acute urticaria, angioedema, contact reactions, or in some cases, an increasing in AD symptoms. But mainly it's different from what we see on atopic dermatitis patients. The prevalence of food allergy in all children in the first 5 years of life is approximately 5%. Whereas in children with AD, the prevalence of food allergy is approximately 30 to 40%, and up to 80% will have high food-specific IgE concentration, even in the absence of true food allergy. However, it's important to stress that this relation is not causative. Rather, the presence of food allergy predicts a poor prognosis of severe and persistent atopic dermatitis. But food allergy does not necessarily cause AD. Egg allergy may be one exception, as up to half of infants with egg-specific IgE may have improvement in their AD with following an egg-free diet. The National Institute of Allergy and Infectious Disease guidelines state that allergy evaluation specifically to milk, egg, peanut, wheat, and soy should be considered in children younger than 5 years with severe AD if the child has persistent AD despite optimal management and topical therapy, or if the child has a reliable history of an immediate cutaneous reaction after ingestion of a specific food. Allergic contact dermatitis is a delayed hypersensitivity reaction to cutaneous allergen that is underestimated in the pediatric population and likely plays a greater role in perpetuating the AD than was previously believed. Up to 50% of children with difficult to control AD have at least one positive batch test reaction to a cutaneous allergen, and the batch test usually look for delayed type hypersensitivity reaction like the allergic contact dermatitis. This is another picture. Clinical manifestations. Major clinical features are pruritic and relapsing eczematous dermatitis in a typical distribution that changes with age. So infants, or the infantile phase, birth to 6 months, the cheeks, scalp, trunk, and extremities are most commonly affected, begins on the cheeks, forehead, or scalp, and then may extend to the trunk, or particularly the extensor aspects of the extremities in scattered, ill-defined, often symmetrical patches. Generalized dryness is common, as my patient had. Exacerbation of facial dermatitis is often seen with teething and initiating foods. At 8 to 10 months of age, extensor surfaces of the arms and legs often show dermatitis, probably because of the crawling and exposure to the environmental allergens. This is a typical but severe picture of atopic dermatitis of an infant from Nielsen textbook. Um, Typically, lesions of infantile AD spare the groin and diaper area during infancy. The sparing likely reflects the combination of increased hydration in the diaper area and protection from triggers by the diaper and inaccessibility to scratching and rubbing. And this is diaper sparing rash. It's very dry on the side or on the legs, on the hand, but it spares the diaper area. The headlight sign has been used to describe the typical sparing of the nose and medial cheeks in AD, even when there is extensive facial involvement elsewhere. And if you see here, the nose is spared, the medial aspect of the cheek, and the same on this child. The childhood face, in early childhood, the flexural areas are characteristic, less likely to have exudative and crusted lesions, and have a greater tendency toward chronicity and lignification, which is a leathery hardening of the skin with increased skin marking. Lesions are characteristically more dry and papular and often occur in circumscribed scaly patches. And this picture reflects the flexural involvement in a child. And this is the well circumscribed patches on the lower extremities. So the classic area of involvement in this age group are the wrists, ankles, hands, feet, and antecubital and popliteal regions. Lymphadenopathy may be a prominent feature in children. Nail pitting or dystrophy may be seen when fingers are affected. This is a picture for lymphadenopathy. You see it's very big on both sides. And my patient has significant lymphadenopathy around her neck, on her inguinal area.
Without skin infection?
That's without skin infection, yeah. That's just probably because of the amount of allergens the skin is infiltrated with and the baseline skin colonization with bacteria. The adult face begins at puberty and frequently continues into adulthood. Hands and feet are typically involved. Areas of involvement include the face, the neck and upper arms and back, and the dorsal aspects of the hands, feet, fingers, and toes. This is a typical involvement on the popliteal area. Regardless of the phase of atopic dermatitis, post-inflammatory hypopigmentation may be seen, and hyperpigmentation is predominantly noted at the site of lignification because of the thickened epidermis, especially in darker skinned children. This is a picture of hypopigmentation. So pruritus or itching is a hallmark of atopic dermatitis, which is often referred to as the itch that rashes, as I mentioned earlier. Other features that support the diagnosis of AD include early age of onset, personal or family history of atopy, ichthyosis vulgaris, and xerosis. Other clinical signs that suggest atopy in general and higher predisposition toward this problem, like white dermatographism, as you see in this picture, circumoral pallor, follicular hyperkeratosis or keratosis pilaris. It's known as the chicken skin. It's very, it's asymptomatic, papular skin on the side of the upper extremities, the side of the thighs. It doesn't bother the patient as much as their mothers. Lichen spinulosus occurs on the trunk and extremities, and it's a well circumscribed area of papules that is also asymptomatic. Atopic pleat or Denny-Morgan lines, it's an edematous extra fold on the lower eyelid. Usually it's present at birth and reflects atopic diathesis. And it's the shiny line, extra shiny line right here. Allergic shiners, slate gray to violaceous infraorbital discoloration. This is from Google. Allergic keratoconjunctivitis occurs in up to 30% of children with AD. Posterior subcapsular cataract, up to 13% of adults with severe AD. So differential diagnoses include inflammatory skin conditions such as contact dermatitis, seborrheic dermatitis, and psoriasis. Usually biopsy and laboratory testing is not necessary to diagnose AD. Infectious complications. So secondary infection, staph is the most common cause of bacterial infections. Staph is isolated from 90% of patients from active lesions of AD patients and 76% from uninvolved skin of the AD patients, compared to a carrier state of 5 to 20% of non-atopic individuals. We should always consider staph as a cause of a flare-up, not responding to treatment, with the absence of active like skin infection per se. These are two pictures of skin infection, one around the eye, one on the hands. Molluscum contagiosum caused by a virus that is a member of poxvirus family. Usually they are umbilicated, skin-colored, shiny papules, and we always say it's like supportive treatment. But we need to treat the underlying skin problem rather than the virus itself. Eczema herpeticum, which is our case, it's a severe form of herpes virus infection that affects children with skin problems in general. Patient present with an abrupt onset of fever, malaise, and widespread eruption of monomorphous vesicles and erosions. The clustering of small round umbilical vessels and punched out erosions are typical lesions. These are two pictures, one around the ear and the other. It looks very similar to our case. Here's eczema herpeticum on the hand, and you see a cluster of small erosions, the same size, monomorphous. This is a bad picture on the eye. This is another one, just from the hair width. The lesions are most prominent in areas of active dermatitis, but especially tend to involve the head, neck, and trunk. Complications of eczema herpeticum include keratoconjunctivitis, secondary bacterial superinfection, fluid loss, and viremia. Ophthalmologic evaluation is indicated when the facial involvement is present. Risk of systemic dissemination, there is 6 to 10% mortality rate, and it needs immediate systemic treatment, antibiotics and antiviral. Effects of AD on quality of life. So the effects cannot be underestimated. Nearly 50% of children with AD report a severely negative effect of the disease on quality of life. Factors that contribute to poor quality of life are fatigue and sleep deprivation, which directly correlate with itch and severity of AD, activity restriction, and depression. Children with severe AD also tend to have fewer friends and participate in fewer group activity than their peers. These children may be at high risk for depression, anxiety, and mental health disorders, along with the limitations in particular in participation in sports. AD has also a negative effect on quality of life of caregivers and parents of affected children. Parents of children with moderate and severe AD spends up to 3 hours per day caring for their children's skin. The most commonly reported negative effects on parents are lack of sleep, fatigue, absence of privacy, and treatment-related financial expenditure, and feeling of hopelessness, guilt, and depression. In fact, the depression rate in mothers of children with AD is twice as high as in mothers of children with asthma. Prognosis. I'm running very fast. AD tends to clear in 43% of children by age 3. Up to 70% of patients clear by puberty. There is seasonal variation of symptoms. It's better during summer and worse during winter when the skin is dry and itchy. They have delayed social development. Asthma, as I mentioned earlier, occurs in 50% of children with AD within the first 2 years of life, along with allergic rhinitis and keratoconjunctivitis. So for classification, the NICE, National Institute for Health and Care Excellence, put these guidelines. Clear is the normal skin. Mild has area of dry skin, infrequent itching with or without small areas of redness. Moderate, areas of dry skin, frequent itching, and redness with or without excoriation and localized skin thickening. In the severe, widespread areas of dry skin, incessant itching, and redness with or without excoriation. Extensive skin thickening, bleeding, oozing, cracking, and alteration of pigmentation. So my patient fall probably in the severe category, so moderate to severe. The management part. So it requires patient and parental education, avoidance of irritant and allergic triggers, skin care that is aimed to compensate for the impaired skin barrier function, and anti-inflammatory medications, topical steroids. So I'm going to talk about each one of them. As you see, it's very easy when you talk about them, but there is a lot of controversy about the use and a lot of problem, I think. We'll go over them quickly. So although there is a consensus regarding practice parameter for the atopic dermatitis, a considerable variability persists in clinical practice, particularly regarding the roles that bathing, moisturizing, topical medications, and allergies play in management. Inconsistencies in opinion and treatment approach, as well as the chronic and relapsing nature of AD, can lead to frustration for the patient, family, and the primary care provider when managing AD. So the first part is patient and parent education. Education of patients and families is a critical factor that should not be overlooked. AD is a frustrating disease because of its recurrent nature, even in the face of excellent care plans. When the primary care provider is able to set realistic expectation regarding outcomes, which is control versus cure, parental compliance is better and frustration is decreased. It can be helpful to discuss the prognosis of AD because most children will outgrow the symptoms or at least the severity of the disease. A study showed that patients whose parents receive comprehensive education regarding AD and its care have better improvement in AD severity than patients whose parents do not receive that kind of education. The second treatment is avoidance of irritants and allergic triggers. Triggers may be unavoidable, but minimizing exposure to them can be helpful. Common triggers may include aeroallergens or environmental allergens, infections, particularly viral illnesses, harsh soaps and detergents, fragrances, sweat, excess saliva, and psychosocial stress. Soft cotton clothing is recommended over wool or other harsh materials which tend to precipitate itching and scratching. Saliva is a major irritant for infants with atopic dermatitis, and exposure to large amount of saliva with teething and eating exacerbate the facial dermatitis. Protecting the face before meals or nap time with a thick protective emollient may be helpful. Cigarette smoking in-house should be avoided since it can lead to increased irritation and pruritus and may also increase the tendency towards subsequent development of asthma. Potential allergen triggers can be identified by taking a careful history and doing selective allergy testing when indicated. Food allergy, as I mentioned earlier, the relation is not causative. Egg allergy may be one exception, as up to half of infants with egg-specific IgE may have improvement in their AD when following an egg-free diet. We should refer children younger than 5 years of age with severe AD if the child has persistent AD despite optimal management and topical therapy, or if the child has a reliable history of an immediate cutaneous reaction after ingestion of a specific food. And we try to refer the patient to allergist, immunologist, or dermatology, but there was some problem with traveling and they could not do it. AAB recommends exclusive breastfeeding for at least 4 months, prevents or delays the occurrence of AD but not asthma in high-risk infants. Maternal dietary restrictions during pregnancy and lactation are not warranted in preventing atopic disease. There is no clear evidence supporting the use of soy-based formula to prevent allergy. There is a modest evidence that AD may be delayed or prevented by the use of extensively or partially hydrolyzed formulas in comparison to cow's milk formula in high-risk infants who are not exclusively breastfed for 4 to 6 months. Solid foods should not be introduced before 4 to 6 months of age, but delaying introduction, including of highly allergic foods beyond this time, does not prevent the development of atopic disease. So in contrast to potential reactivity to foods, reactivity of children and adolescents with atopic dermatitis to aeroallergens increase with age. House dust mite, grass pollens, animal dander, and molds are among the aeroallergens. Skin care, which is the most important part of management. Regarding the role of bath, I was doing dermatology at that time, and there is a lot of opinions. Some people say you have to bathe the baby as much as possible. Other people say absolutely that's wrong. And the truth is, the bottom line is, there's no study done to compare the rule of bathing in children with AD. So it's still controversial, but I believe it's a balance, like in between. It's a balance between replenishing the water loss and losing the skin lipids with frequent bathing. So the specific frequency of bathing should be titrated to the individual patient and his or her response to bathing. Most experts recommend limitation of the bath to approximately 10 minutes to prevent loss of endogenous cutaneous lipids. Avoid excessively warm baths and showers. Application of thick emollient within 3 minutes after exciting the bath before evaporative loss occurs. Use only mild soaps such as Cetaphil, Dove, Pezes. Bubble baths are contraindicated because of the irritation. An extremely important component of maintaining skin hydration is lubrication of the skin, commonly referred to as moisturization. Frequent moisturization alleviates the discomfort associated with xerosis or dryness, and that should decrease the itching and helps to repair the defective skin barrier and reduce the quantity and potency of pharmacologic interventions. In a British study evaluating 51 children with AD, parents were educated on the proper use of moisturizers and topical treatment by a nurse specialist. During the study period, the quantity of moisturizer used increased by 800%. Average use was 426 grams per week per patient, while the severity of AD decreased. The percentage of patients having to use moderate or potent topical steroid decreased. And I'm not sure if anyone knows how much 426 grams per week. I did a picture. This is just a jar, I think 500 grams next to my cup. Studies comparing the relative effectiveness of specific moisturizers are lacking, and the plethora of products can make the task very hard. All moisturizers are a mixture of lipid and water. Ointments have the highest proportion of lipid. For example, petroleum jelly has 100% lipid, and likewise feel greasy when applied to the skin. Creams and emulsions are much more tolerable. They still have oil more than water, but they contain preservatives and stabilizers to keep these ingredients from separating. But they can be a source of irritation because of the preservatives, and they can burn and sting. Ointment tend to have the greatest moisturizing effect, followed by cream and then lotions. The best moisturizer for patients with AD are basically fragrance-free and have the least possible number of preservatives because these are potential irritants. Commonly used products, Cetaphil cream, Eucerin, Lubriderm, CeraVe, Aquaphor. Moisturizer should be applied at least once daily to the entire body, regardless of whether active dermatitis is present. There are a handful of prescription barrier creams. They did a study comparing these with the over-the-counter one. They did not find any difference in the severity of the atopic dermatitis, but they are more expensive, so they are not cost-effective. The addition of dilute sodium hypochlorite, which is the bleach, fourth a cup to half a cup per full tub or a scant teaspoon per gallon to the bath is helpful in controlling the dermatitis of children who has history of skin infection. For children who would like to swim, so they recommend applying thick emollient after sunscreen application as a protectant against the high concentration of chlorine, and rinsing immediately after swimming with the application of moisturizer, and that can decrease the risk of irritation. Air conditioning is important during hot weather to decrease the itching. Heat rash or miliaria rubra, a pruritic and erythematous papules resulting from emollient blocking sweat gland, usually, or it can confuse parents with exacerbation of AD. And these are more common with ointment or blocking agents. So topical anti-inflammatory medications. So topical steroids have been the mainstay of treatment for atopic dermatitis. They are the first line, most commonly used medication to treat active atopic dermatitis and have been used for the last 40 to 50 years. Topical steroids are classified according to their potency and the vasoconstrictive ability for the drug from class 5 to class 1. Class 1 is the super potent one. And class 1 medication are 1,800 times more potent than the least potent class, number 7. Inexpensive, low and moderate potency generic topical steroids are hydrocortisone and triamcinolone, and depends on triamcinolone concentration, and the carrier is ointment or cream. It can be from class 3 to class 4. Acceptable limits for the primary care physician on topical steroid is using low potency topical steroid for the face, neck, and skin folds. These are the most susceptible skin for side effects, and moderate potency topical steroid for trunk and extremities. High potency medications are generally not needed. You may use them in adult on palms and soles, but should not be used in children. This is just a chart from Hurwitz regarding the use of topical steroid. I already said them. So use appropriate potency steroid to quickly gain control of the flare. Continue daily use until active dermatitis is minimized. And they found that setting a specific how many days you need to stop it usually causes undertreatment of the dermatitis. So they should continue it until the dermatitis is minimized. If it doesn't go by within 10 days to 15 days, they should go back to the primary care physician. A study showed that risk of relapse in moderate to severe AD is significantly reduced by proactive maintenance with twice-weekly application of mid-potency topical steroids on the active or the recurrent lesions. Flares of dermatitis are unlikely to respond to moisturization alone, so you should use a topical steroid. Management should not be just concentrated on the treatment of acute flares, but also should be directed towards improving the underlying skin barrier dysfunction. When we use appropriately, I always put something about appropriately because this is, I think, a hard stuff or a hard part to know what's appropriate and what's not. We don't use topical steroid that often. We use them mainly over the counter or class 7, class 6. However, when used inappropriately, there are potential risks of cutaneous atrophy, stria, telangiectasia, systemic absorption with resulting adrenal suppression. There are also other potential local effects when used around the eyes, like intraocular hypertension, glaucoma, and cataracts, or around the mouth dermatitis. Because of these potential risks, there is a real phenomena of steroid phobia on the part of both parents and healthcare providers, although this phobia does not correlate with the AD severity. So it does lead to undertreatment of the skin disease. The face, as I mentioned earlier, the face intertrigous areas are the most susceptible sites and may show local effects even when weaker steroids are used for prolonged periods. Small children are at greatest risk of systemic absorption of topically applied steroids. The other anti-inflammatory medications, or the medication that we use to control the flares, are topical calcineurin inhibitors, tacrolimus, that have been approved for the last decade by the FDA, and it's approved for children above 2 years of age. It can cause burning or pruritus in small percentage, does not show the atrophigenic potential seen with steroids, can be safely used on the head, neck, and intertrigous areas, no increase in cutaneous infection, no adverse effects on systemic immunity. There is a theoretical risk, I think it has a black box in it, of causing skin carcinogenesis and lymphoma. But there was no case reported, as far as I know. The role of antihistamines. So the itch, the pathogenesis of the itch it's not really dependent on histamine. So histamine plays a minor role. Non-sedating antihistamine is probably not helpful, but class 1 or antihistamine is helpful to get the child sleep, mainly not the itch itself. The last part is appropriate social and community support resources, such as referral to a counselor, psychologist, patient support group, such as the National Eczema Association, can be helpful when quality of life issues are encountered in patients and families with AD. Just one more thing. So my patient was 3 or 4 months old when he started having this problem. It was generalized from head to toe except the diaper area, as you saw there. So the hard question was, do I use topical steroid? If I'm using topical steroid, should I cover it from head to toe? And what kind of topical steroid? All of these, they don't have an easy answer, and it's easy to refer. But this specific example, they could not do it. So I have to come up with a plan. Unfortunately, she was admitted to the hospital with the eczema herpeticum, and I have a plan for the next patient. So I think the safest thing to do is like over-the-counter or class 7 or 6, or class 7 on the face and intertragus area, and moderate steroid, even class 3 on the other part, because you need to get control over the itch cycle. If you don't get control, these patients are like at high risk for many, many problems. I think that's it. I think I have one more picture. These are my references. This is any other question? Any questions? Over-the-counter hydrocortisone, class 5, and they generally do not recommend it for a long period of time. So the time that needed to control the itch mainly.